However, I was insistent, for example, that we not perpetuate the myth that people are allergic to iodine, and if you have a quote-unquote iodine allergy, that you are also allergic to radio contrast media. And so our radiology department was very supportive of that, although we did have end users suggest that we should semantically group, for example, shellfish allergies with radio contrast media allergies, where nothing could be further from the truth. The allergen with the shellfish allergy is a muscle protein, and the allergy with radio contrast media is probably not even mediated by typical hypersensitivity mechanisms. It seems to be that it's a direct stimulation of, and I know this is kind of medical technical lingo, but radio contrast media directly stimulate the release of histamine. So there were a few of those issues, but generally that's the only one I can think of, and they were relatively minor.
Well, great. So we have a couple other questions. The next question is, you had mentioned that you would have made clinical documents first. Why would you have made clinical documents first?
Because it turned out to be, after we rolled out phase 1 with our pilot group and then continued to roll it out to another 1,500 to 2,000 users, it was probably the most requested new data to include in the system, and it may have been the overall #1 request overall, except for possibly we had a minor issue with Microsoft Active Directory where we were displaying the wrong field, and which showed them as users as being in the wrong department. So surprisingly, users complained about that the most. Which was a minor thing that we got corrected. But the #1 feature request, data request, seemed to be clinical documents. And the reason for that seems to be, narrative. The clinical narrative is still what is most helpful to clinicians when they're learning about a patient, learning about what happened to a patient, and still is what they seem to go to first.
Well, great. Next question we got was from Otto, and his question is, what is the role of LOIN in creating semantic interoperability for lab results?
So we did translate our laboratory test codes to LOINC, as it's called for short. It stands for Logical Observation Identifiers, Names, and Codes. It played a central role in our efforts, and I think nationally there's really not much of any other choice. CPT, which is short for Current Procedural Terminology, has codes for laboratory tests, and I know that's how they get billed, but the granularity is definitely not sufficient, and LOINC is per every recommendation I've ever seen, the recommended standard for laboratory test code identifiers. And so we definitely used it. It was 75 LOINC codes, again, that I mentioned, that made 140 million of our 180 million test results semantically interoperable. So it's got a very important central role, I think, nationally, and it certainly did in our efforts, and it's what we used.
Well, the next question, Bill, is do you think vendor products will comply with the standards in the future? And if so, how soon?
So that's a great question, and it's, my guess is as good as anybody else's. The problem has been, in my opinion, incentives, and because consumers of their products haven't put it front and center, they haven't built it in. And the reason and I'll put myself and all healthcare delivery organizations into the same boat on this, we as customers haven't been demanding it, because we really haven't had a good financial incentive to share data with each other. And that's why all the community health information networks of the 1990s failed, because there was no financial incentive to share data, and why even with the resurrection of data, cross-organizational data sharing efforts in 2003 and 2004, the regional health information organizations, some very prominent ones, have failed, and it's because of the business model really hasn't been there more than anything technical. So I think the reason vendors aren't standards compliant is because they haven't had the financial incentive, and the reason they haven't had the financial incentive is because their customers haven't had the financial incentive and demanded it, and the reason their customers haven't had the financial incentive is because our payment system is the way it is, and I won't belabor that point. But meaningful use criteria is starting to change the incentive. So meaningful use criteria do require data exchange outside your organizational walls to get the incentive payments to some extent. And I'm not facile with the letter of the meaningful use criteria, and they're still in flux. The final rule for meaningful use criteria has yet to be approved. But I think there's hope. I think vendors are at the table. I think they're starting to look at standards. I think they're starting to implement them. Certainly we chose dbMotion as a vendor partner because they were founded, their foundational data model and their core philosophy, and sort of at the center of everything they do and everything they've built thus far has been standards-based. But I think progress is being made in terms of timeline. I'll make a prediction that, say, this is a bold one, 80% of vendors will be able to exchange problem list medications and allergies using a continuity of care document standard with standard terminologies in it within 5 to 7 years. And, that I give that a probability of about, 70% of occurring. That's a wild guess.
Wow. Well, we do have a number of questions, and Bill, we have about a minute left, so I think we could take one, and some of these questions that were asked, we could definitely follow up after the webinar here today. But let me ask one additional question, and this question is there any update on using the CCD?
So, is there any update on using the CCD? So, we were working with dbMotion very closely. We certainly recognize that as CCD gained mindshare and our affiliated physicians came to adopt electronic medical records that were CCD compliant, they were going to both want to send to us and receive from us a CCD. So they want to send us a CCD when they refer the patient to us, and they're going to want a CCD back when the patient comes back from the hospital or whatever specialist. So we have been very strategic in working with dbMotion to do that. I think we had some discussions about piloting the CCD in the context of a personal health record project, but I don't know what the current status of that is.
Well, we're running out of time here, so if there are any additional questions, feel free to submit them, and we will send them along to Bill for his answering. So thank you, Dr. Hogan, today for this wonderful presentation. The Western PA chapter of HIMSS, the HFMA of Western PA, and 5-Star Development would like to thank you for sharing your experiences with us. They were very insightful. We would also like to thank you, the attendee, for attending today's webinar. We appreciate you took time out of your busy schedules, and we hope that you received value from your time investment. The Western PA chapter of HIMSS strives to provide valuable programming to its members, and after you exit the webinar today, you'll be asked to complete a survey. We would greatly appreciate your feedback, as it really helps to refine programming and webinars going forward. If you'd like to learn more about the chapter or to become a member, you can visit the Western PA HIMSS website. And if you would also like to learn a little bit more about the HFMA of Western PA chapter, you can also visit their website. And then finally, again, if you would like to learn more about 5-Star and the solutions that we provide for gaining clinician adoption of new processes and technology, you can visit our website at www.5stardev.com. So again, we appreciate your time and your participation, and thank you ahead of time for completing the survey. Again, thank you for joining us. Goodbye, and we wish you the best of luck.